Okay. Thank you, Ashraf. We're running about 5 minutes behind, so I want to move forward and go to the next talk and speaker. Our next speaker is Jeremey Walker. He's recently joined the faculty at UAB, former chief resident and ID fellow here, now doing transplant ID, infection prevention and stewardship in the transplant patient. And he's going to provide some tantalizing information about the potential relatedness between COVID and cryptococcal disease. So Jeremey, thanks for being here, and look forward to your presentation.
Thank you so much for having me. It's really an honor to have this opportunity, and thanks in particular for Dr. Pappas for inviting me today. So I do want to talk about COVID-19 and Cryptococcus. I do not have any disclosures. And our objectives today are going to be to review some of the relevant background for this particular entity, as well as to discuss our initial case series from our institution. And so background, and this is things that I know many on this call know all too well, but cryptococcosis is caused as an invasive yeast infection, was predominantly by Cryptococcus neoformans, which is really kind of ubiquitous throughout the world, and more recently, significant reports with Cryptococcus gattii, which seems to be predominant in certain regions and is known to have increased virulence. It generally originates in the respiratory tract, but then can disseminate to many organ systems, but the one that we are the most concerned about is CNS involvement. And this has been really prominently described in patients who are immune suppressed with cell-mediated immunity, HIV/AIDS, and solid organ transplant, but of course can be seen even in patients who are presumably immune competent, although there's always some question about potentially underlying genetic risk factor or other disease presence. Within the solid organ transplant in particular, there is a concern for reactivation of quiescent infection, a concept that potentially there is a small amount of Cryptococcus that can then has the opportunity to reactivate and generally causes a more subacute presentation. The median time to onset in SOT is within that first to second year post-transplant, so a higher immune suppressed period, but not the highest risk period that we tend to think of for opportunistic infections. And really in all populations, both solid organ transplant, even HIV/AIDS to an extent, and then particularly for our immune competent hosts, there is a long history of description of delayed diagnoses and many patients presenting with headaches for weeks to even at times a couple of months before a lumbar puncture is performed and the diagnosis is made and confirmed. As far as invasive fungal infections following viral pandemics, it's what we've been discussing today, and we've heard from many speakers who are much smarter than me and have a lot richer experience in this. But what we know is that Aspergillus in Canada have been well described as flu pandemics, and we've been hearing about how Aspergillus nigrales in Canada, as well as other fungal infections, have been seen post SARS-CoV-2. Multiple mechanisms involved with this, and of course I can't go through all of them, but a combination of the hyperinflammatory state with high cytokine storm, downregulation of cell-mediated immunity, breakdown of your mucociliary clearance system, and then, of course, the steroid use and other immune suppressive medications that we've been discussing. So I wanted to first start by reviewing what has been reported with Cryptococcus for these viral pandemics. So within influenza, there's actually only 4 isolated case reports that Fong et al. Actually put together in 2019 for us. All were in the setting of a pandemic flu, either H1N1 or H7N9. And in all of these patients, they were critically ill with influenza, admitted to an ICU, and during that primary admission developed Cryptococcus diagnosed by culture data. These patients had a high mortality rate, 3 or 4 died, and a high rate of CNS involvement. This is, of course, a very critically ill population to begin with because of the influenza, but none had any traditional predisposing risk factors or immune compromising conditions. This is a list of the 6 isolated case reports that I could find in the literature of cryptococcosis following COVID-19. I updated this over the weekend. It is limited to English language. I know there's at least one that I'm missing because of that limitation. But what you'll see here is, again, many of these patients are older with some comorbidities, but only one in the traditionally more high-risk patient population with a deceased donor kidney transplant, a few that had diabetes that is also a known risk factor for cryptococcal disease. But these were all, again, critically ill patients with COVID. So most required mechanical ventilation, all required ICU stay. All were in their index hospitalization with COVID or had just discharged to a facility when the symptoms and diagnosis of Cryptococcus occurred. And you can see that happen anywhere from 2 weeks post SARS-CoV-2 to 10. Most were disseminated. All of these were proved by culture. You can see 3 were blood cultures and 2 actually had evidence of CNS involvement. And again, here in this patient population that began by being critically ill by COVID, but then complicated by Cryptococcus, a very high mortality rate. So 5 of them died, and the one that survived required a BP shunt and a prolonged hospitalization following, so a very complicated course. So that leads us in really to a description of our cases, which was presented earlier in ID Week poster, and so that can be referenced as well. And I included at the end of the slides for those who are interested as they're shared. But our case details are a little bit different. So these cases were all seen at our institution. We have a small group of transplant ID providers and a weekly case conference. And it was in that conference that this kind of recognition of a pattern in a couple of patients emerged that led us to go back and look through all the patients with a diagnosis of Cryptococcus that we had seen since SARS-CoV-2 began, and look at the timeline between SARS-CoV-2 diagnosis and cryptococcal disease. And from that, we've identified 6 patients that are documented here. We've actually had even a couple other reports come in since that time from other providers we've shared this information with. You'll see that these are traditionally immune suppressed patients. So one with simultaneous liver kidney transplant, one with simultaneous kidney pancreas, 2 deceased donor kidney transplants, 1 with a heart transplant, and then 1 who was on chronic methotrexate for an inflammatory uveitis. But all of these immune suppression regimens were stable. There have not been any recent changes. The one patient number 1, which we'll talk about, was within their first year post-transplant. So they were in the highest level of immune suppression, but their regimen had actually been tailored down to their stable dosing. What is also unique about these patients is none of them had a COVID diagnosis requiring ICU level care. 2 of these patients were actually managed outpatient with supportive care only. They did not even have steroids as part of their home regimen and did not get a course of steroids. The ones that were admitted were primarily admitted for remdesivir or for close monitoring on dexamethasone, but none, again, required mechanical ventilation or ICU level support, and all had discharged home before cryptococcal diagnosis was made. 3 of these patients did present with CNS symptoms, and we'll talk a little bit more about that on the next slide. 2 presented with more respiratory symptoms consistent with pulmonary involvement, and 1 had evidence of a cellulitis. The patients that had CNS involvement actually were very complicated. And so 1 required a VP shunt, 1 was complicated by multiple strokes, which has been described with cryptococcosis. And then the final 1 had what was truly an immune reconstitution syndrome response that developed after their initial line of treatment, which again has been described in our transplant population. But all of them are doing well, or at least stable at follow-up with some improvement. There was no mortality in this population. So a very different looking group than what we looked at that has been reported in the literature previously. And so this is a slide I'll orient you to. This is at the bottom here is when the SARS-CoV diagnosis was made, and you can see it following out from there. The line would represent when the best we can outline from the patient's story, the symptoms kind of began, with the box representing the actual time of Cryptococcus diagnosis. And then we'll talk a little bit about these as we go through. So the first patient, which was the one that was closest post-transplant, actually had just presented to clinic for a routine follow-up appointment. a fairly stoic lady and had just said that she felt a little short of breath, but actually ended up having O2 stats in the mid 80s. And so she got admitted and worked up, and both results came back at the same time, a high positive crypto antigen, as well as a SARS-CoV-2 PCR-based test that was positive. Her imaging was consistent actually with both. She had a nodular component that was more consistent with Cryptococcus, but then a diffuse kind of viral interstitial pattern that would be consistent with SARS-CoV-2. And she responded to treatment for both inpatient for a period and then eventually discharged home. The next two patients both presented within a month of SARS-CoV-2 diagnosis. They both had more disseminated symptoms. One had respiratory, the other had the cellulitis, both had fevers that were not responding to antibiotics. And both of those ended up having positive blood cultures for Cryptococcus. And then the final three all developed symptoms more closely related to the SARS-CoV-2 diagnosis between that day 40 and day 75, but had delays in diagnosis going up until almost 12 weeks post SARS-CoV-2 diagnosis. And for especially these two in particular, if you read through the chart, much of that delay was because of attribution to long COVID syndrome. So the patient had fatigue, headaches, nausea, and those were attributed to that rather than to the cryptococcal infection that was eventually diagnosed. All of them grew Cryptococcus from blood cultures, and all were treated with induction therapy. I will note that all of these cases are with Cryptococcus neoformans. All of these cases actually occurred earlier in, at least the SARS-CoV-2 occurred earlier in the pandemic, or at least before the most recent Delta wave variant came through. And all of these occurred before vaccination and monoclonal antibodies, at least that patient was able to receive. So I want to highlight patient 4 because I think that particularly tells the most interesting story. So this was a 62-year-old gentleman with a heart transplant, had been on stable immune suppression though for a long time, actually had known history of cryptococcal meningitis back in 2013 requiring a BP shunt. And he had completed 18 months of total therapy at that time, had followed in clinic regularly. A decision was made to discontinue, appropriate with kind of our general treatment course. And he had done well off therapy since 2015. He was one of the two that had a very mild COVID in the winter of 2020, just some upper respiratory symptoms, was diagnosed by PCR as an outpatient, was treated really with supportive care only, did not even receive steroids. And then he was one that was readmitted later post SARS-CoV-2, but again had a 40-day lead-in period where he was having headaches and other symptoms, but there was just a delay in diagnosis, in part because of his being from a more rural area and not easily able to follow up at the transplant center. And again, with positive blood cultures and CNS cultures for Cryptococcus neoformans. He responded well to induction, but did require another BP shunt for his pressure management. And so, and really, I think here what we can make is observations. We're really limited in what we can say. We just have 6 patients that we're able to present, but there really does appear to be a temporal relationship between SARS-CoV-2 and the cryptococcal presentation in these patients. I mean, these are all patients that are immune compromised that do have other risk factors for Cryptococcus, but as we see, the timing does seem to follow the timing that we would expect as far as how the disease propagates from the lungs, disseminating into the bloodstream, and then eventually into CNS, and the delay between diagnosis that we see kind of correlates with that. I think the other thing that's telling is the patient that we just reviewed, a patient who had been well controlled for several years off therapy and then had reactivation of disease after the SARS-CoV-2 diagnosis. We also see these are patients presenting that really had mild COVID, some of them not even requiring hospitalization as compared to some of the patients that have been described in other places in the literature, but they had a different time course as well. Their progression of cryptococcal disease followed a more subacute kind of timeline much more consistent with what we typically see with Cryptococcus, rather than the more fulminant courses described in those isolated case reports for patients who are critically ill in the ICU with other things. They were complicated infections, particularly those with CNS involvement, but our population compared to the other two groups I described, there was no mortality, which is significant. And then there's also the commentary around the delays in diagnosis and the attribution to long COVID syndrome that I think is a very important thing to remember, particularly for those who are caring for patients who have other underlying immunologic deficiencies that may predispose them to Cryptococcus beyond this. And another reason that we really need to investigate this further. And so really the next steps is to try to get more data so that we can better characterize this and really know if there is something to this pattern that we're seeing. And so the MSG-ERC is helping us to coordinate a call for cases. We have a case report form developed and are working with our IRB. We are defining this as really a cryptococcal infection that's been confirmed either by antigen or presumed by cryptococcal antigen testing or confirmed by positive culture data with symptoms that began within 90 days of the SARS-CoV-2 infection. And the period that we're looking at is really March 2020 through October 2021. And we would just please contact if you have any cases that you would like to contribute as soon as we're able to actually open that up to receive those cases through survey, we will. As I close, I just want to acknowledge the many people who have supported me in this, most notably Dr. Pappas, who's here, but also Carolyn Jones and Rachel and the whole study team who has helped us, as well as several of the fellows who helped me put together these cases. And then, as I said, my last slide for those who want to look at them when they're shared does have that poster as well, if desired. Thank you so much.
Thank you, Jeremy. To answer a quick question from one of the in the chat box, yes, they were all Cryptococcus neoformans. We'll get back to these questions at the end of this session.